Good morning, everyone. I'm Sandhya Khurana at the University of Rochester, and it's a pleasure to be with you all today, although virtually. I want to thank Dr. Brosnahan and the New York State Thoracic Society Planning Committee for this kind invitation. So I'll be speaking on severe asthma with focus on phenotyping and biologics, and I think it's a timely topic with many new biologics now available. These are my disclosures. The research funds are directed to my institution, and I receive royalties for a textbook on severe asthma that I recently co-edited. So our understanding of asthma has evolved over time. Asthma used to be considered a single disease. Then we thought of it as intrinsic versus extrinsic asthma. But then over the years, a lot of efforts from many different asthma cohorts and programs has really done a lot of great work on phenotyping and helping us understand the heterogeneity of asthma. And the last decade has been particularly eventful with the availability now of many biologics for treatment of asthma. And this table from the updated 2021 GINA guidelines also includes phenotypic assessment and consideration of biologic therapy in step 5 of their algorithm. And these are patients who are uncontrolled on medium or high dose inhaled corticosteroids and a long-acting beta agonist. And these patients, of course, have had their diagnosis confirmed, comorbidities addressed, and adherence optimized. And if they remain uncontrolled despite all of that, then it's really they have severe asthma and they should be considered for advanced therapies. And a longstanding approach, I think, for all of us has been to categorize asthma based on observable characteristics. And these are phenotypes. For example, patients whose asthma is allergy-driven or allergic-driven when they're around certain triggers, or early versus late onset asthma, or patients who have low lung function or fixed airflow obstruction, or obesity-associated asthma. So these are all different phenotypes of asthma. Endotypes are distinct biologic mechanisms that explain these phenotypes. So for example, within patients who have eosinophilic phenotype, their asthma could be driven either by interleukin 4 or 13 or interleukin 5 or IgE mediated. And then biomarkers, of course, are measures of phenotype or an endotype. Asthma is an umbrella term that includes many different phenotypes, but it's been broadly separated into two buckets based on their type of inflammation. This is type 2 high asthma or non-type 2 or type 2 low asthma. Examples of type 2 high asthma include allergic asthma, which can be childhood onset, or later onset, adult onset, sensitizer-induced occupational asthma, the more severe eosinophilic asthma that is associated with nasal polyps, or aspirin exacerbated respiratory disease. So cluster analysis from different cohorts have traditionally sort of aligned them along age of onset and then type of inflammation. And examples of non-eosinophilic or type 2 low asthma include infection-related, particularly in the preschool under 6. There's a lot of respiratory infection-related wheezing, and that can be type 2 low. Obesity-associated or metabolic syndrome, systemic inflammation-associated asthma, irritant-induced asthma are other examples of type 2 low asthma. And sputum has been traditionally used to characterize airway inflammation in asthma with a broad categorization into 4 categories based on the predominant cell type. Eosinophilic, neutrophilic, mixed granulocytic, or polygranulocytic. The mixed granulocytic has both eosinophilic and neutrophilic inflammation and tends to be more severe and less steroid responsive and more refractory to therapy. Polygranulocytic is the most common phenotype we see in mild stable asthma. Sputum, however, is very time-consuming, cumbersome, and not always successful, and has remained largely a research tool. And blood eosinophils has really become the surrogate marker of eosinophilic asthma, and have been used successfully to select patients in recent trials of asthma biologics. They're low cost, they're easy to use, and this graph here, this ROC curve, shows that they correlate. This line in red is the eosinophil count. They correlate well with sputum eosinophils. The exhaled nitric oxide levels here, and this is periostin. So sputum blood eosinophils correlate quite well with sputum eosinophils. The one thing to keep in mind, of course, is the variability in blood eosinophilia. So if initial evaluation does not reveal elevated blood eosinophils, I usually repeat at least 2 more times to ensure that we're not missing patients who may have treatment effect or recent steroid use. Down here, this curve, this first plot shows the risk of exacerbation with increasing blood eosinophil count. So eosinophils are also a predictor of exacerbation. Exhaled nitric oxides correlate with epithelial expression of inducible nitric oxide synthase, which is upregulated by STAT6 upon activation by interleukin 4 and 13. So exhaled nitric oxide level, which is becoming increasingly available at point of care testing and easy to use and do both by children and adults, is an attractive biomarker of IL-4 and IL-13 activity, and has been shown to predict response to most of the biologics. Now, IgE, allergen-specific IgE, and skin testing, of course, have been used as biomarkers of allergic asthma and are helpful to identify patients who will benefit from omalizumab or anti-IgE therapy. Periostin is an extracellular matrix protein that is associated with increased IL-4, IL-13 activity, and was being developed as a biomarker to predict, to select patients who would respond to an anti-interleukin 13 antibody lebrikizumab. But that was a negative study, and periostin has not made it to clinical use so far. As you can see, all the biomarkers that are currently available are really type 2 targeted and have significant overlap. These are data from the International Severe Asthma Registry that was published last year, over 1,000 patients from 10 countries. And they looked at eosinophils and Ig and found significant overlap with 27% of the participants positive for all 3 biomarkers and about 60% positive for 2 or more. I want to review the immune mechanisms behind type 2 high asthma, because I think understanding them would really help increase our understanding of how to select biologics and where they work. So the immune response in type 2 asthma can be triggered by exposure to allergens, infections, or pollutants. And once the airway epithelium is exposed to these triggers, it secretes these 3 epithelial cytokines, also known as alarmins. So these are interleukin 33, 25, and TSLP. TSLP, there's been a lot of buzz because tezepelumab, the most recently approved biologic, targets this cytokine. There are 2 other biologics that are in phase 2 of development that target interleukin 33 as well. And epithelial cytokines are important because they are, this is the most upstream that we have gotten for our targeted biologics. Now, the allergic immune response in asthma is largely mediated through the T helper cell 2. So dendritic cells, which are antigen-presenting cells, once they are activated, they activate T helper cell 0 or naive T cell into T helper cell 2. And that then secretes the 3 most important cytokines involved in the type Th2 immune response. And these are interleukin 4, interleukin 13, and interleukin 5. IL-4 and 13 then lead to class switching of the B cell with release of IgE that then activates and degranulates mast cell and basophil, leading to the allergic immune response. So IgE is where omalizumab or Xolair acts. Interleukin-5 is directly responsible for eosinophil activation, maturation, their survival, and leads to eosinophilic inflammation. And the anti-IL-5 antibodies, there are 3, target this site. Interleukin-13, in addition to participating in the allergic pathway, also lead to airway hyperreactivity and mucus hypersecretion. And in the last decade, we've also learned about an alternate innate immune mechanism in type 2 high asthma, which drives the non-allergic eosinophilic pathway. These are driven by the type 2 innate lymphoid cells, or ILC2s, that secrete IL-5 and IL-13. So omalizumab was the first biologic that became available in 2003, and as I mentioned, targets IgE and allergic asthma. And then we had a hiatus of about 12 years, but starting in 2015, almost yearly, we've had a new biologic become available, starting with mepolizumab in 2015, then reslizumab in 2016, and benralizumab in 2017. Mepolizumab is also Nucala, reslizumab is Syncare, benralizumab is Fasenra. All 3 target the IL-5 pathway with some subtle differences, which I'll go into in the next few slides. And then in 2018, dupilumab became available. It targets interleukin-4 and 13 pathway and is more upstream and has a broader impact than the other biologics prior to that. And then, of course, the new kid on the block is tezepelumab that targets TSLP and is really the only biologic that can target both type 2 high and type 2 low asthma, or treat type 2 high and type 2 low asthma, and became available in December of last year. So really just 3 months old. So let's start with omalizumab. Omalizumab binds to the free IgE at its high affinity receptor and targets the allergic pathway. And it is approved for use in moderate to severe allergic asthma, where the serum IgE ranges from 30 to 700, and there's sensitization to more than 1 allergen. There is a small risk of anaphylactic reaction of 0.2%. So the treatment has to be initiated in a healthcare facility, but in low-risk patients who tolerate initial therapy well, there is an option now of continuing with home administration, and it is administered subcutaneously every 2 to 4 weeks. And there is robust data because it's the first biologic that was approved a long time ago that has shown exacerbation reduction, both exacerbations requiring corticosteroids and exacerbation requiring hospitalization, with about 40 to 50% reduction and significant reduction in healthcare utilization. It is also approved for use in patients with urticaria and nasal polyposis, and is the only biologic that has significant reassuring data for pregnancy. So in patients who are already on omalizumab and get pregnant, this is an option to continue this safely. And a biomarker analysis and correlation with omalizumab efficacy was performed in this extra study where Nick Hanani was the lead author, and included 850 participants. And while omalizumab was overall 25% effective in reducing exacerbations, in patients who had elevated exhaled nitric oxide levels, eosinophils, and periostin, the efficacy was significantly higher. So these high type 2 biomarkers predict omalizumab response. Now, for anti-interleukin-5 therapy, mepolizumab and benralizumab are available as subcutaneous injections. Benralizumab has the advantage of 8-week duration intervals after the initial 3 injections, so slightly more convenient. Reslizumab is weight-based, and the only biologic that is administered as an IV infusion every 4 weeks. So there is a theoretical benefit or advantage in patients who may have very high eosinophils or high BMI, as they can get weight-based dosing, but there is the added inconvenience of needing to be given in an infusion center, and there is a small risk of anaphylaxis of 0.3%. There are also differences in their mechanism of action. While mepolizumab and reslizumab block interleukin-5, benralizumab is actually a receptor blocker, and in addition to preventing the binding of IL-5 to the eosinophil IL-5 receptor, it also has the ability to bind to this Fc gamma receptor on natural killer cells and result in antibody-dependent cellular cytotoxicity and apoptosis of eosinophils and basophils. So it can lead to very rapid depletion. The other thing to keep in mind is that mepolizumab is also FDA approved for use in hypoeosinophilic syndrome, EGPA, as well as nasal polyposis. So in patients who may have those comorbidities, this could be an attractive option. And over the next few slides, I just want to quickly review the exacerbation, the efficacy data for these IL-5 antibodies. Mepolizumab, this DREAM was a dose-ranging study and showed significant reduction in exacerbation of 40 to 50%. And the 75 milligram IV was chosen based on this study and led to this pivotal study, phase 3, resulting in FDA approval, where IV was compared to 100 milligrams subcutaneously, which was the FDA approved dose, and associated with 53% reduction in exacerbations. Similarly, reslizumab, this was a large study of 953 patients using an eosinophil threshold of 400 cells per microliter, while for mepolizumab, that was 300 cells per microliter in the last year, or 150 cells per microliter at randomization. For reslizumab, 400 cells per microliter was used for inclusion criteria, and again showed a significant reduction in exacerbations. Benralizumab, same story, 2 large studies showed again significant exacerbation, slightly less effect here, but that's was thought to be because the control arm patients had at baseline fewer exacerbations when they were enrolled, and the eosinophil, all comers were enrolled, but eosinophil cutoff of 300 cells per microliter was used for analysis. And predictors of response for both mepolizumab, which I've included here, and also for benralizumab, are a baseline exacerbation frequency and a baseline eosinophil count. And for example, here, as you can see, in patients who had 4 or greater exacerbations, you could see the separation at a much lower eosinophil count compared to those who had 2 previous exacerbations. Dupilumab is an anti-interleukin-4 receptor alpha antibody, and it binds to the alpha receptor alpha subunit, and which is participates in both IL-4 and IL-13 activity. So as a result, dupilumab can block both IL-4 and IL-13. There are 2 doses that are approved, a higher loading dose, and then 200 or 300 milligram every 2 weeks, approved for home administration. Also has FDA approval for atopic dermatitis and nasal polyposis, and approved for corticosteroid-dependent asthma, even in patients where eosinophilia is not demonstrated. The higher dose was used in patients who had corticosteroid-dependent asthma. And again, the approval was based on large studies that demonstrated significant exacerbation reduction, especially in patients who had eosinophil count greater than 300. So this is a phase 2b study and a phase 3 study, again showing a significant decrease in exacerbations. Both the FeNO and Ig levels were reduced over time with the dupilumab, but the studies did show transient eosinophilia at about 16 to 20 weeks. Most of the time, this was not clinically significant therapy, but about 4% of the patients did have a quite significant treatment-emergent eosinophilia. And this here slide shows the predictors of response, patients who had either elevated FeNO or blood eosinophil count greater than 150 cells per microliter had a good response to dupilumab. Importantly, even in patients who had a blood eosinophil count less than 150, if they had exhaled nitric oxide levels that were elevated, it did predict a response, was associated with improved response. Now, tezepelumab data was just published. The phase 3 study was published in New England Journal just last year. This had a lot of excitement with it because in addition to targeting, or in addition to being involved in the type 2 high pathway, TSLP also has potential to impact type 2 low asthma. So this study included over 1,000 participants and found a 56% reduction overall in patients with severe asthma who were enrolled regardless of their eosinophil count. So the overall population had significant reduction, but when separated by their eosinophil count, even in patients who had low eosinophil count of less than 150 cells per microliter, there was about 40% reduction in exacerbations. And when subgroup analysis was performed, this was a pre-specified exploratory analysis. Even though there was sort of an increasing efficacy based on their eosinophil count here, and based on the exhaled nitric oxide level, even patients who had low biomarkers had significant improvement in exacerbation. So tezepelumab, based on this, is approved for ages 12 and greater, patients who have severe asthma as add-on therapy, regardless of their eosinophil count. I also wanted to share this slide with you that there are only 3 asthma biologics that have been systematically studied in oral corticosteroid-dependent asthma and found effective, and these are mepolizumab, benralizumab, and dupilumab, and generally found about 50% reduction in maintenance oral corticosteroid need while improving both symptoms and exacerbations. Tezepelumab was studied as well in corticosteroid-dependent asthma in the SOURCE trial, and the preliminary data presented at ATS last year was a negative study for decrease in maintenance oral corticosteroid use with a very large placebo effect. And although patients in the treatment arm did have improvement in lung function and exacerbations, the corticosteroid use did not decrease. This is just asthma biologic efficacy at a glance. I just wanted to highlight that the inclusion criteria for all these biologics was very variable, but exacerbation reduction was very similar, and then the 3 biologics would decrease in oral corticosteroid use. The improvement in the quality of life and asthma control was statistically significant, but generally did not cross the minimal important difference, and except for mepolizumab, where SGRQ did cross the minimal important threshold. There was also modest improvement in lung function. And if you haven't seen this review paper in New England Journal of Medicine published in January of this year, I would highly recommend it. This was from Guy Brissell, and I've taken their approach to selection of biologic. I really liked it, and it's very similar to the approach I use in my practice. So in patients who have mild to moderate eosinophilia, really any biologic is an option, and selection is guided by their biomarkers and comorbidities and their preference, and also the insurance formulary, or what would be approved. In patients who have very high blood eosinophil count after ruling out other etiologies for hypereosinophilia, I do go with an anti-interleukin 5 strategy because just shutting off the eosinophils with IL-5 is very effective in these patients. I have become more hesitant to use dupilumab in patients with very high eosinophils just because of the noted eosinophilia in clinical trials and also post-marketing case reports of some eosinophilic diseases. In patients who don't have peripheral eosinophilia after repeated check, but have high serum nitric oxide levels, depending on their allergic phenotype, they could either qualify for anti-IL-4 or anti-TSLP or omalizumab if they have an allergic triggers. For patients who have both low EOS and low FeNO but are still allergic phenotype, again, anti-Ig and anti-TSLP are options. But if they don't have allergic asthma, then this box, which was empty until 3 months ago, now has one option, which is this anti-TSLP antibody. This is approved, forgot to mention, for home use This is approved for administration by a healthcare provider every 4 weeks at a fixed dose of 210 milligrams. Of course, once we start patients on our biologics, we assess for response 3 to 6 months later. And if they're non-responders, move on to alternate biologic. If they are good responders, you continue. But the response has to be assessed using objective parameters. I want to quickly share our own real-world experience that we published last year in 112 patients with severe asthma with 44% on maintenance oral corticosteroid. And we found that biologic therapy was associated with significant reduction in clinically significant exacerbations as well as oral corticosteroid use. But also want to highlight that 1 in 4 patients needed switch to a different biologic due to suboptimal response. And when they were switched, they did have a 40% reduction additionally in exacerbations and also non-significant decrease in oral corticosteroid use. So just some final thoughts, exciting times to be in this field and to be able to offer all these new advanced therapies to our patients who have severe asthma. In this day and age, management of severe asthma must include phenoendotyping with available biomarkers and then considering other characteristics and comorbidities guide selection of biologic therapy with close monitoring and follow-up for treatment response using objective criteria. And then patients who are non-responders stop and consider switching to a different biologic or revisiting their diagnosis and reevaluating their phenotype. But there's still many questions that we don't have answers to. For example, there's no head-to-head comparison studies showing efficacy of these biologics, so making selection of an initial biologic difficult. Duration of therapy in patients who respond is not known. Again, targeted therapies, apart from tezepelumab, we don't have many for non-type 2 asthma. So I'll leave you here. Thank you for your attention, and I look forward to answering questions in the live portion of this conference.